and I'm going to be leading this session today on our showcase session of the creation of our PLICS Waiting List Analyser. So if I just take over everyone's screen, I've got some slides if I just get up and start from the beginning. So hopefully everyone can see the slides that have just popped up on the screen. So just to give a bit of a background, obviously we're here to talk about the creation of our PLICS Waiting List Analyser. And everyone might be thinking, well, you know, we're Tom, you're an accountant, you're part of a finance team. How on earth have you got involved in population health management? So just to give everyone a bit of a background, the costing team at Leeds, we have a really good reputation within our trust of being very innovative and transformational in the way that we use our data and the way that we present our data. So we have a really good reputation of being able to lead on a whole host of different projects. Now, about a year ago, we discovered what we like to call the power of the postcode, and really begin to understand what sort of data can you begin to externally get and align with your data sets just based on those few numbers and letters. And that's not just about, you know, where does a patient come from? It's about how deprived the area they come from is. You can pull more information about, you know, what happens in that area, such as smoking rates or diabetes rates. And we've really begun to discover all the sort of information that you can get just off that one bit of data. Now, as I mentioned earlier, we have a really good reputation of being very innovative, and word gets around quite fastly about, you know, all the sort of collaborations that we've done with our clinicians. There might be some stuff about projects such as, you know, how do we better improve our patients? How do we potentially find waste reduction? But also our ability to create other bespoke population health management tools that we have in the past. We've done a few, just some, for example, we've got one that covers our A&E data so we can understand our patients attending A&E. We've got one about our maternity pathways to understand, you know, does, for example, where someone comes from impact, you know, their quality of care they receive, and one about our outpatients as well. And we also have a Twitter account, which I'll shamelessly plug here, which is at our THT costing team. And that's really helped us to do the same of get word to get around. And you'll see that, you know, a lot of our clinical teams are on Twitter, and that's really helped us to really engage with them. Now, about a year ago, again, we were approached by a couple of different clinicians that were wanting to seek our help with how can we begin to use our waiting list data to overcome many of the problems that we might have. So the problem that we have within our trust that I'm sure everyone here and across the country will experience is that COVID has resulted in a significant patient backlogs in our elective waiting list, because obviously we really had to reduce the number of electives we were having through only having patients who needed to be seen at that very moment. And obviously that's meant a lot of patients have had delays for treatment, and we're now sort of seeing the outcome of that with a lot of patients waiting. Another outcome that we're seeing from that is that our patients are actually deteriorating because they've had to wait for a longer amount of time. And as a result, we're seeing patients who are more complex, and they might even begin to present acutely and place pressure on our unplanned care services. For example, you know, we've seen that currently within nationwide, our A&E attendances are absolutely through the roof. And just having our patients constantly deteriorate is putting an even more unnecessary pressure on those unplanned care services. Another thing that's really important across the NHS at the moment is, you know, equity of access and making sure, you know, how do we ensure all of our patients get the same sort of level of care or access to our services. And that's a really important bit of the NHS's current 5-year plan. So we really wanted to be able to find a way of how do we monitor and make sure that everyone's getting the same level of treatment and access to that treatment. Finally, we wanted to understand, you know, these patients are going to have to come in and be treated at some point. What sort of resources would there be required in order to treat all these patients? So we wanted to be able to create a way of supporting the planning and costing of all of these resources. So what we went about doing is beginning to create a tool, and this tool we'll go through in a few minutes, but we had to create a solution that answered many of our questions that we had so far. So one of the really important things we had to do was try and understand what was the ask of this tool and of our clinical colleagues, and what were they really trying to want to get out of this. And for us, that was the things that we just went through previously, such as are patients having to wait a different amount of time or getting different levels of access to treatment based on, the color of their skin, for example, as well as are patients more likely to be attending our acute services just because they have had a delay in being seen. We really needed to be able to understand the data. And obviously for us, we're accountants that work within the costing team. We typically report on, what's happened within the trust, patients that we've actually treated. So for us, trying to understand a waiting list data was a very foreign thing to us. We really had to sit there for a little bit, go through the data, try and understand what were the key fields, and really engaging with our clinical colleagues to get them to help us with that. We also had to begin to link multiple different data sets together. We've talked about obviously the waiting list data, but bringing in that external data from ONS, for example, about where does a patient live, how deprived is that area. We really begin to have to understand how to exactly link these data sets to create something that was bigger than the sum of its parts. We also really had to be able to understand how do we begin to transform this data and create it into useful information that people can read, understand and report on. And to do that, we have to create something that's focused so that really begins to get to the point quite quickly, be very visual so that people can understand it quite easily. Even though we're accountants and we love tables and numbers, that's not always what our clinical colleagues are interested in. And finally, impactful as well. So we really had to be able to understand, how could we, show people the ultimate benefits or the current impact of doing this. And our solution to that, you can see in the very final point there, was to create something that was interactive, that our users could use and play around with and begin to really have a deep dive into the tool. So I know some people have possibly read our innovation submission and be really interested in having a quick demo of our PLICS Waiting List Analyser. So what I'll do is I'll just go through an example now so I can show you what it looks like and how possibly it could be used. So what I've got open here is our PLICS RTT Waiting List Analyser. And the way this tool works is on the very top here, you can see a whole host of filters and slicers, which allow us to slice and dice the information. And that's our way of really making the tool interactive and allowing you to have a deep dive, as well as a whole host of different buttons on the bottom here that allow us to change the way these charts and further ones below look, again, to allow for interactivity. And we'll go through a couple of examples of how we can just play around with those in just a moment. We also have a few headlines on the very top here, which just allow us not only to set the scene for our current waiting list, so we can see how many patients are waiting, how long are they currently waiting for, and how many have presented acutely, but it allows us to be really impactful and get to the numbers very quickly, so people can quite quickly see, how long are people waiting, or when we've made a selection, how many of these people have presented acutely. Now, the way the tool works is we've got three main sections. There's one section which has a look at average waits, which is this very section on the top here. And what this allows us to do is have a look at how many patients are currently waiting for each one of our services. So each one of these here is a service such as our abdominal medicine surgery, and how long are they currently waiting for. So for AMS, we can see there's about 2,800 patients that are currently waiting for surgery, and they're waiting about 31 weeks on average. On the right-hand side here, we have the top 20 procedure codes that patients are waiting for. So within our trust, we have a surgical booking form where people are required to enter what the procedure is they're waiting for. And that allows us to better understand exactly why patients are on the waiting list. And we can just see which ones are the most number of patients waiting for. So extraction of multiple teeth is the very top one here. How many patients are waiting in total, and what are their average wait in weeks. We then have a second section of the tool, which begins to have a look at some acute presentations. So within this section, we're really trying to understand, for the people currently on the waiting list, have they presented either at our A&E or our surgical assessment unit acutely whilst they've been waiting for treatment. And what we can see in this very top chart is at a very high level how many patients have attended acutely. So within AMS, if we have a look again, about 350 of those 2,800 patients have attended acutely, and that's about 12% of the patients overall. And it does vary quite a bit for each one of our different services. So we can see AMS and our women's service stand out, but there's other ones like our cardiorespiratory that are much, much lower. So we can see it does vary quite a lot. If we scroll down to our next chart, that begins to break down our acute presentations as to whether they attended our A&E, which is our green both bubble here, which is our number of attendances and the total cost of the attendances in the bar, or our SAU, which is just one of our assessment centres, which is in the purple here. So we can really begin to see, how many patients have attended, did they attend either A&E or SAU, and what was the financial impact of that? How much has that costed us for either their attendance at either one? The final section is where we really begin to have a look at some elective recovery. So obviously, all of these patients on the waiting list, we want to be able to treat as quickly as possible. So within this elective recovery session, we've begun to highlight what is the sort of resource requirements in order to treat all of our patients. So to do that, what we've been able to do is using the procedure code that we've seen previously that should be entered on our surgical booking form, we're able to go back to our PLICS historic data to understand how much do our patients typically cost, or how long do they typically stay in hospital, or how long are they in theatre as well, to really begin to build up the number of resources we're required. We're not able to quite cost everyone up, and as you can see here, there's about 3,000 people alone who don't have a procedure code. So we do have our own data quality issues within here, and where they don't have that procedure code, we're not really sure, how much they're going to cost. So we're able to highlight where there are data deficiencies within the data for them to then be tackled. But what we can see is how much resources are required to treat all these patients, either in terms of cost on the very top here, which is about £26 million in total, in beds in the middle section, and that's split down into either a standard inpatient bed, which is the orange, or a critical care or HOBS bed in the greeny blue colours here. So we can see overall we need about 34.5 inpatient beds and 2.3 critical care beds to be open for a whole year in order to treat these people, and that's assuming at a 90% occupancy rate, and we know we're even busier than that at the moment. And then finally, we're able to do exactly the same on the very bottom, but having a look at our theatre requirements. So we're able to see how much operating time do patients need and how long will they be needing in recovery for. And again, we can just do a quick conversion into how many 4-hour sessions do we need in total to treat all of these patients, which is about 2,500. So I mentioned earlier, excuse me, I mentioned earlier we have a whole host of filters and slices on the very top here. And what they allow us to do is to look into certain specialties or certain areas or certain patients to really begin to do a bit of a deep dive into this analysis. And what we'll do is we'll go through an example of how we can just do that right now. So if we have a look at this very top chart, one of the CSUs or services that sticks out a little bit is our neurosciences service, where patients are out waiting on average 33 weeks for their treatment currently. If we wanted to be able to have a deep dive into this neurosciences service, we can do so using the slices on the top. So if I just select neuro, what that will do is it will change the charts you see here, below, and everything else throughout the tool, just to have a look at our neuro patients. Now, neuro is quite a big service. We might want to have a look at what specialties make up our neurosciences, and we can do so using the buttons on the very top here. So if I just click on this specialty button, what that will do is change all the charts we see to then have a look at a specialty view. So we can see there's quite a lot of activity within adult spines, about 800 patients who are waiting 45 weeks on average, followed by pain, but their patients aren't waiting nearly as long. So we might want to do a bit of a deep dive into our adult spine service and really understand why are these patients waiting so long. So again, using the slices on the top here, we can just click on our adult spine service. And then that auto updates right so we can see it there. We can, for example, bringing in all of our population health management information, begin to have a look. Does someone's ethnicity or age or deprivation, if I just click on this deprivation button, have an impact on the likelihood that someone is or isn't to attend? Again, what we can see is patients in say deprivation index 1 to 3, which is the most deprived areas of the country, they're a bit more likely to attend, around the 11 or 13%, than patients in say deprivation index 8 or 9, which is the least deprived or the most affluent areas of the country. So they're not very likely to attend. So we can see, there's a bit of a disconnect, and begin to ask those questions of, why is that? Is it that patients are presenting onto our pathway already more complex, so they're having to attend quicker? Is it that there's not the opportunity for them to access their primary care, so they're having to come to our ED, for example? And it just allows us to ask those questions. Another one that we're going to click on is this top 15 acutely presented procedures button. And what this allows us to do is have a look at what procedures are patients actually waiting for on the waiting list. And again, it's quite small, it's a bit hard to read, but on this chart here, we can see, which procedures are patients more or less likely to need to present acutely for. And one that we're just going to pull out here is this V333, primary anterior excision of lumbar intervertebral disc. I won't say all of it because it's massive, where there's 11 patients waiting on the waiting list in total, and one of them's had to attend acutely. So if we wanted to sort of do a deep dive into this procedure, again, we can, and there's a procedure filter on the very top here. So I can just quite quickly enter V333 and select OK. And we're then really focusing down on just these patients within this one procedure code. So we're at some really detailed level. There are then a couple of further tabs within this spreadsheet. The second one is our patient level detail tab. So within here, we show each and every individual patient that's included within the analysis, and we have anonymized it for the sake of this presentation, but each one of these rows is an actual patient that's currently waiting for treatment, and we can just see what are they waiting for. There's an operation text, which is a free text description within our surgical booking form, so a consultant can write a bit more detail in exactly why they are waiting. We can see when they're originally added onto the waiting list, how long they've been referred, and then if we scroll right to the end, we're able to have a look at whether any of these patients have presented acutely. Now, we know there's only one of those patients that has, and we can see them on this second line here, where they've actually attended A&E 5 times, have costed £800 in total, and they've been waiting since December 2019. So it's just tipping over 3 years now when we have a look at it, how long they've been waiting. So we're really able to understand, how many patients are waiting, and is it just one patient regularly attending, or is it many patients are having to attend once? Something that we've more recently built into the tool, because we've always wanted to be able to constantly develop our tools and create them more and more useful, is this final tab here, which is an acute presenters detail tab. So within here, we just bring in a bit of information as to exactly why that patient has attended, because it's perfectly reasonable that a patient might be attending for something completely unrelated to why they're on the pathway. And if we just show how many patients have attended, we could, be leaning into creating a bit of misleading data. So we really wanted to be able to, allow our users to begin to have that deep dive analysis so they can really understand why patients are attending. And we can see it's this one patient here who's attended 5 times in total. What we're able to do is say, where did they attend? So this patient attended our A&E, and exactly when did they attend? If we scroll further onto the right as well, crucially, we can bring through something that's from our A&E attendance data set, which is called the chief complaint. And this is essentially a bit of an explanation as to why is the patient attending. And we can see they've attended for an injury of the lower back, some backache, and some limb weakness. When they're attending our adult spine service and they're coming in for injuries of back or backache, we can quite confidently say that this is probably related to the reason why they're on the waiting list in the first place. Now, one of our clinical colleagues who we've worked quite closely with in creating this tool, they've then taken this data one step further and began to engage with our adult spine service to really try and understand what is happening and why is this patient having to attend our A&E multiple times. And as it actually turned out is that this patient was obviously sent to us to go on the elective pathway, but the GP that they're a member of isn't actually subscribed to pain management services that are available across Leeds. Now, as a result of that, obviously, they've been slowly deteriorating over time up to the point where they've had to regularly attend our A&E. And we've been able to capture that now and offer that patient pain management service. They don't have to attend our A&E. But unfortunately, they've been on the pathway for almost 3 years, deteriorating. It's actually got to the point where this patient is no longer able to work their full-time job. So, we can see, patients that are having, or, are now slipping through the cracks because of, things that aren't offered in their GPs or the area that they live in, for example. And we can actually begin to really see the impact of that. And, this is a person at the end of the day that has a life and is now, no longer able to work. So we can really quite quickly see what sort of data that we can pull out, and doing that bit of external reviewing of patients, we can begin to understand how can we improve the pathways that we offer. So if we just go back to the slides. So that's one of the outcomes that I've mentioned from creating this tool and beginning to use it, but there are others that our initial deep dives have revealed. There's a few up here just for an example. So one that we've been able to find is that a patient's ethnicity actually can have an impact on weights. Within one specialty, for example, we've seen that Black British patients are having to wait on average 15 weeks longer, which is obviously quite a significant larger amount of weight. We've seen in other areas, again, we've mentioned can there, because in other areas it does or doesn't have an impact. So having the ability to really deep dive and being interactive allows you to quite quickly pull out those those pieces of information and make a bit of a bespoke analysis for all the different areas that we're talking about. We've also been able to see a lot of correlations between the number of acute attendances that we've had by different PCNs. So a PCN is a primary care network, which is essentially a group of GPs in a local area that are work quite closely together. And we do see that there are correlations where some are having a far more number of acute attendances. And again, that just highlights questions of perhaps do they not quite have the access within primary care? Are their GPs really stretched to the point that they can't get an attendance there, so they're having to come to our A&E or our surgical assessment unit instead? And we've mentioned as well, that from the example we've just looked at, that we've been able to discover that not all of our GPs subscribe to our pain management service. And one thing that our adult spine service has done following that is, checking up on our patients and making sure, if they're not subscribed to a pain management service and they need it, we are able to offer that ourselves, and can we make sure that we're offering that so that patients aren't deteriorating to that point again. So throughout this, we've had a whole host of learning outcomes, but there's 3 outcomes that I think are really crucial. They're ones that we've taken forward into other bits of analysis or other bits of collaboration that we've worked in the future, and they're ones that I think everyone could really benefit from. So the first one of those is that collaboration is key, and working quite closely with our clinical colleagues, it's really important that we try and understand the ask, what they're wanting us to help create, and working together to create that solution. And that's not just having a meeting at the start and having a meeting at the end when you've created your analysis. It's about having that constant back and forth throughout the whole time, and you really begin to understand what are their needs throughout that, rather than having to go with them right at the end and possibly not having something that quite fits their bill and it taking a bit longer to where you want to get to now. And that collaboration really helps with the next point about really trying to understand what are the key metrics that you're trying to demonstrate and create using our analysis, and how easy and what is the easiest way in showing those key metrics so that people can quite quickly get to the point, really try and understand what is the data telling them, rather than having to look, constantly look at many different charts and just to get to one answer they might need. The final point is really how important it is to structure your analysis and trying to avoid overwhelming your users with too much data at once. And you've seen that we've created things like slicers, things like buttons that use Visual Basic to change the way charts look, to really make it as easy as possible for a user to look at just what they want to have a look at, remove all of the noise, and don't show all that too much data at once. And again, through the collaboration, you'll really begin to understand what sort of data they want, and anything that isn't key to them. It's about, what do we perhaps just remove it or not show it at all from the analysis, because it just keeps creating too much noise. So that's it from me. That's all the presentation I had. I just wanted to say to everyone, thank you for your time. And if anyone has any questions, if I just stop sharing my screen, feel free to put your hand up or just jump in, and I'll try and keep an eye on the chat as well if anyone has anything they want to mention. So I can see Peter's added a question into the chat. So Peter says, thanks, Thomas. Does this get presented alongside traditional PLICS stuff, or has it stolen the limelight? I think this and our PLICS stuff are both very different, Peter. I think a lot of people will always be looking at our PLICS stuff to try and understand the patients that we've treated, and having a look at waste reduction opportunities. But the stuff that we see within the waiting list analyzer is a different, very different view, because it's looking forward. It's something that's, not really being done with PLICS necessarily very much. Certainly at our trust, having a look at using PLICS to look forward. So I think they're very separate, and they can get sort of seen alongside, and anyone can jump into either one that they want to at any point, rather than this just taking the limelight from PLICS, for example. I think they're almost intertwined and can work together. So Tom's asked, did you already have all the data collected to create this? How long did it take to put together in its current format? So for everything that we had here, we had almost all of the data previously. Most of it's made up of our most of the stuff we had already is our PLICS information. There's a bit of information we pull from Office of National Statistics about, where I mentioned the power of the postcode, everything about how deprived is an area, where do patients come from. We pulled from ONS. The key bit we didn't have for this piece of analysis that we've been able to incorporate is our waiting lists, because that's never really given to a costing team being talked about in the past. So what we had to do for this was collaborate quite a bit with our informatics team to understand, where is this data, where does it sit, and how do we get like an automated view of this, so that we can almost run this whenever it's needed, rather than having to constantly go back and forth with informatics. That did take a little bit of time, so not wanting to almost wait for that to happen, we did use like a standstill version of our waiting list for once upon a time, so that we could begin to create the analysis. In terms of how long it took, probably from the very first prototype to the initial analyzer, probably took a month or two. But it's always in constant development. As I mentioned, the final tab was something that we added in a few months later. So we're always constantly looking at this tool and any tool to constantly be updating it, and trying to make it better as we get a bit better information, or we work closely with our colleagues. So Rob's asked, thanks, Thomas. What costing system do you use, and how does the data feed into the analyzer? So the costing system that we use is IQVIA, but IQVIA's costing system and the data within here don't really have much of a link. The only thing that we really use from that is the raw costs that are fed out from our costing system. All of the other stuff that's really used in there is the other data feeds we put into costing, like our SUS data, for example, to understand what patients attended A&E, but it has very limited interaction with the actual system itself. We pull quite a lot of the other stuff straight out from SQL, where we host our data. Caroline's asked, was this data totally created by the costing team or with the informatics department as well? So the raw data wasn't really created by us, because we, as I just mentioned, the SUS bit, the waiting list analyzer, that was all pulled from informatics with their support. But the actual amalgamation of the data and the actual creation of the analyzer itself, that was done completely by us within the costing team. One thing that we did say a couple of years ago is we began to look at Power BI and really try and understand what can we do with Power BI. And we thought Power BI was brilliant, but unfortunately we don't have a Power BI license within our trust. So what we wanted to do was begin to try and take all the learning and all the cool things you could do in Power BI and begin to do that within Excel. And that's how we've been able to create the analyzer that you can see today. Peter's asked a follow-up question saying, did the costing team pick this up as no one else was available, or was the costing team chosen to add particular value? I think it was probably the latter, Peter. Is we've got all of that goodwill and all of that good reputation from the whole host of other analyzers or projects that we've done in the past, that people really begin to see us, the costing team, as like a resource and someone who's able to create good analysis and not just that, but add in the costing information as well. Because if, for example, the informatics team has done this, they perhaps wouldn't have added in the costing information, such as the future expected resources, because they don't necessarily use PLICS or even have access to it. Most of them don't really have access to it. So I think here we are really seen as the go-to team to create analysis like this or any others. As you've seen, I mentioned we've got probably 4 or 5 other population health management tools. So people are coming to us regularly rather than coming to informatics. Richard just said, did you consider using Power BI rather than Excel, so I've just answered that question. And Jack McIntyre says, Leeds is a big hospital. Are there any issues with size processing of the spreadsheet? So the actual spreadsheet itself for this one, we don't really have any particular issues with this one, partly because we're only looking at our elective waiting list, which is about 12,500 patients. So what we're able to do is when we create our data in the back end, we take out all of that noise. Any sort of bits of data that we don't want, we'll remove that in order to make this data set as small as possible and gives us everything we need. And then when we feed it into the tool that we've just seen, it runs well. And hopefully you have seen that it is relatively fast, and it doesn't do itself churning away. We have had a few other problems like that in other tools where we have so much data that we just can't fit it into our spreadsheets. The outpatient one is a really good example of that. What we've done for that is that we've created the data to be stored within SQL, and that our Excel has an external connection directly into our SQL table, just to minimize the amount of data we have within the tool. And that does make it far smaller. So if you wanted to send it out or save it anywhere, it is much smaller, and also just far quicker to use, so that when people are using it, it is much more quicker and it is more interactive. Caroline's asked, how often is the data refreshed? So within our PLICS Waiting List Analyser, we do this one on an as request basis, because we understand people are using it quite a bit. It's probably about every couple of months, maybe every 6 weeks at the moment, and it just is as and when we get asked for this one. For a lot of our other ones, if they are much quicker to refresh, or we know they're being used, we might do them monthly or quarterly. For example, we do set up like an almost publishing timetable for other ones. Are you matching the acute presentation timeframe to the waiting list timeframes in the background? Yes, we are. So with everyone who has been added onto the waiting list, we are given an understanding of when they exactly were added on through a date, obviously. And then when we have a look at our acute presenters, we only take in any attendance that's had after they've been first added to the waiting list. So anything that might have happened before is completely excluded from this. So we're able to really try and look at just that exact time frame that we want to be looking for, because we don't want to bring in attendances that aren't related to the reason that they're in there, and overstating a problem, or making analysis that is possibly wrong. I don't know if anyone's got any questions they want to shout out. I know people have been adding things in the chat, and I think I've answered everything. But if anyone else has got any other comments, feel free to add them in or shout out. Andy, I've seen you got your hand up.
Hi Thomas, thanks for that. Really good presentation. Just wondering about, you showed the bit of data about the extra 15-week wait for the black British patients in certain CSU. So now that you've got that knowledge, has that CSU acted on that?
So what typically happens is, within this example, we work quite closely with one of our clinical colleagues who asked us to create the tool. They've then presented that data back to the CSU, and the CSU is now in the process of doing their own deep dive, really having a look at why exactly is that, because it might be perfectly reasonable that these patients are more complex and they need to, they are waiting for example, a critical care bed, which we know is a very finite resource. But our clinical colleagues who asked us to create the tool, they then work with the CSUs or the services themselves to really begin to have a deep dive into the data and understand why.
Brilliant, thank you.
Okay, I don't know if anyone else hasn't got any more questions. Right, so I think if we've got nothing else, we're good to end there, Becky. We're just happy to.
That was all good. Thank you.
Brilliant.